Welcome back to the Hot Flash Diaries podcast. This is episode number 4, dedicated to Polycystic Ovarian Syndrome, or PCOS, and specifically PCOS in perimenopause and menopause. I am honored to be joined by my dear colleague, Agnes Lussier, today. She is the Hot Flash Diaries' first guest. Agnes is an Ontario board-certified nurse practitioner in primary healthcare. She has a wealth of experience spanning from the emergency department to primary care to occupational health and latest in aesthetic medicine. Since 2009, she has been dedicated to delivering high-quality, evidence-based healthcare. And as the founder and owner of NP Optimal Health and Wellness in Peterborough, she is an advanced functional medicine clinician and employs functional medicine approach to addressing complex health conditions such as perimenopause, menopause, PCOS, thyroid disorders, and she also treats both men and women with testosterone replacement therapy. Her holistic approach marks a significant shift from conventional medicine, moving from treating symptoms or isolating symptoms only to understanding the body as an interconnected system focused on disease prevention and optimal health, hence the name of her clinic. Thanks so much for being here today, Agnes. I'm so excited that you've joined us.
Thank you, Jessica. And by the way, before we get started, I wanted to say that I loved how you explained the highway, a hormone highway in your last podcast, and specifically the role of estradiol, progesterone, testosterone. It was great. It was like I was taking my friends on that highway. So if anybody hasn't listened to that, great understanding on estradiol, progesterone, and testosterone, which will help you understand this even more. Anyways,
Thank you so much.
For that.
Yeah, it was tough to come up with an analogy that sort of made sense and people could imagine, and I thought, who hasn't been on a road trip? So It was perfect. So actually with that, on the road trip, we were chatting about bringing along insulin, how if we had a bigger car, we would have brought insulin along. And sure enough, it was sort of a prelude to today's episode about PCOS because insulin is a big part of that. But before we get there, I wanted to chat a little bit about the diagnosis of PCOS as we were taught from a conventional standpoint, right? Like we both went to our NP school, prior to that, our nursing school, did our master's, and we were taught in a very conventional way how to diagnose and treat PCOS. And the way that PCOS is diagnosed, it's based on 3 specific criteria or symptoms that women sort of have to meet 2 of 3. It's called the Rotterdam criteria, right? Do you remember that?
Mm-hmm.
Of course you do. And so there are 3 things. So the first one is a woman, in order to be diagnosed with PCOS, has to have irregular periods or no periods at all. She has to have some clinical or biochemical markers, meaning some lab findings or physical examination findings that suggest hyperandrogenism. So things like facial hair, oily hair, acne, or just general skin changes. But a lot of that is that hirsutism or the hair, male pattern sort of hair growth. And then the third criteria is the polycystic ovaries on ultrasound. So in order to be diagnosed, a woman has to meet 2 of 3 of those conditions, or of course they could have all 3. Now, I'm not sure how you used to practice before you got into functional medicine, but myself, I would always order labs and an ultrasound, even if a woman, I could easily diagnose her with PCOS based on her clinical findings and her history. I would still order ultrasound, and I would also order a whole lab panel because I wanted to rule out things like thyroid conditions or issues with the adrenal glands.
Mm-hmm.
That extra little bit of information would give me reassurance that my diagnosis was indeed that of PCOS. But then from there, I sort of felt helpless because there weren't many options of how I could help these women. And I would either give them birth control if I knew that they didn't want pregnancy or want pregnancy currently because their periods were irregular. Sort of that period of ovulation was so unpredictable that, a woman could easily become pregnant if she didn't know when she was ovulating. And also having that ability to have periods monthly with being on oral contraceptives or not at all with something like a Mirena IUD also helped a woman to feel like she was like her friends who didn't have PCOS, right? I found a lot of women had troubles and concerns around the fact that they didn't have periods every month, and that was really distressing for them. But then the women who wanted babies, those were the ones I felt even more helpless, right? Because, okay, so I can't give you birth control. I could give you metformin. That's the other thing I'm told to treat you with. To increase insulin sensitivity is how I understand it now. But back then, the emphasis on insulin sensitivity really wasn't there. And then also to send to a fertility clinic immediately, because a lot of women with PCOS do have difficulties with conceiving. And sort of that was out of the primary care wheelhouse. So sending them off to fertility was sort of the next appropriate step. Beyond that, that's all that I had to offer, right? And so it was really an area of medical treatment that I felt inept and underqualified to treat. So when I started taking my functional medicine courses and my bioidentical hormone replacement courses and really diving deeply into all things women's health, I had this huge eye-opening experience when it came to PCOS, because I actually understood the underlying condition, right? And
Absolutely.
so it's so exciting to connect with colleagues like yourself who understand it in the same fashion and treat it the same way. It's so exciting because I think there is an opportunity to provide a lot of women hope who are experiencing PCOS, but also women who are heading into perimenopause and menopause who perhaps weren't even diagnosed with PCOS and they've had it for years. And now they're sort of in this in between of PCOS and also then perimenopause and menopause. So it can be a very sort of stressful time. So it's really exciting to have you here because I feel like you are an expert in this department. So tell us all the things.
Thank you. I'm learning all the time, but I feel the same way. In one of the many things I learned in doing training with Dr. Neil Lussier, as you could probably attest to, regarding PCOS, I'll never forget him standing there saying, treat everyone with PCOS until proven otherwise. And that has totally changed my practice considerably. And, you know, there's so many women that are undiagnosed. And yes, we'll do the blood work and the ultrasound, but it still doesn't show up. It's not until we take a very detailed history and maybe family history that makes me think, okay, there's some insulin resistance or insulin effect happening here. And sometimes they don't see it in the reproductive years, but it comes full blown in menopause. And I just had a woman yesterday, you know, which was like, you had this all along, but managed it, you know, and then so with more research in functional medicine, you know, looking at root causes, we've come to learn from the physiology and studies more about PCOS and that it is a metabolic and endocrine disorder, right? It's associated with hormone imbalances, but insulin resistance is the one of the main root causes. So
Exactly.
So I forget who it was, not Dr. Fung. And it was somebody on WorldLink that had mentioned PCOS and ovaries are just an innocent bystander. Really, it's
Exactly.
the insulin resistance and the metabolic issues that are happening that we, when understand it and address it, can have the biggest impact, better than any drug on the market, right?
Well, that's exactly it. We thought for the longest time that this was considered to be a gynecological condition, right? So something that a gynecologist would manage. But as it turns out, it's more of an endocrine consideration or condition, right? Where again, it's that pancreas that is, you know, the insulin pancreas sort of access and the sensitivity to the insulin that it's producing. That is really what's happening here, where there's that decrease in sensitivity. But like you said, the ovaries are just an innocent bystander. It's a cause effect. It's not a causation per se. It's not the reason why PCOS is happening. So it's very fascinating. And when you look at it from an insulin resistant standpoint and treat it as such, that's when women start to feel better and we're able to help them with a lot of their symptoms, right?
Absolutely. And once we understand the metabolic challenges, that really takes center stage, right? Insulin is a hormone produced in the pancreas, as you mentioned, And its primary job is for your body to use the glucose or sugar from the food we eat. So
Exactly.
let me explain the insulin effect. So when we eat food, our body breaks it down to glucose. The pancreas gets signaled and excretes insulin because insulin's required to transport the glucose from the bloodstream to inside the cell. And that's every cell in our body, our muscle, our brain, our stomach, our liver, every cell in the body, because that's what our body needs for energy and function. And low glycemic foods, take their time making glucose. So the pancreas sends insulin in moderate, steady levels. It's like, okay, we can handle this. But then when we get to high glycemic foods and eating all the time, that raises glucose quickly. So the pancreas, sends an abundance of insulin, of glucose transport. You could just imagine that. The pancreas is saying, oh my gosh, we've got so much glucose on board here. We've got work to do. So time after time after time with that same, those same food choices and eating, our pancreas says, wait a minute. It sends out more insulin until a point where it says like, okay, can't handle anymore because the cells aren't absorbing this and the cells become resistant. So
Exactly.
we get that almost hypoglycemic effect, and it's a vicious circle because you're eating, but you don't have the insulin to put it into your cell. So then you have this hypoglycemic effect where your sugar drops and you think, I better eat again. And now you're putting more glucose into your bloodstream, but it's still not going into your cell. This, in turn, creates the hyperinsulinemia, or high circulating insulin in our system. And our cells are resistant to it, right? So there then becomes a domino downstream negative effect that affects all of our bodies. And yes, we'll talk about ovaries, and it presents more in women, and with the androgen or more male type symptoms, but mostly fertility in our reproductive years. So when we have all that high circulating insulin, it goes to the liver and signals the release of sex hormone binding globulin. And sex hormone binding globulin is a protein produced by the liver, and it binds to hormones like testosterone. I call him the gatekeeper. It's like either more or not enough, right? So,
Yeah.
what
It's a
happened?
little transport molecule, right?
Yes.
It's like a bus. It loads up the hormones and it takes it to places where it needs to go. The problem is when you have too much of it, right?
Yeah. Or not enough, because
Exactly.
then when it releases the sex hormone binding globulin, or actually decreases it, it binds to the hormone testosterone, and there's more floating free testosterone in our circulation, which exacerbates the symptoms, setting off a chain reaction that worsens that androgen dominance and symptoms that we see in PCOS.
Right.
And the high insulin, though, there's kind of like a double whammy, because that high insulin also goes to our ovaries. Our ovaries need insulin.
Yes.
And in the ovaries, it produces more than normal testosterone. Like our ovaries are producing testosterone. It's not just a male hormone. We love it.
That's right.
We want it, but it produces it in higher than normal. Right, which perpetuates the PCOS symptoms even more.
Exactly. Yeah. So you've got this extra testosterone that's being made, but then testosterone that's not going where it needs to go because there isn't enough of that sex hormone binding globulin.
And the high testosterone in the ovary actually stops. We have this wonderful mechanism, our body, of protecting itself, right? So the body senses that it's not in a good metabolic state, right? So the testosterone goes to the ovary and it stops that follicular development, right? And it's called follicular arrest. This is the phase where the corpus luteum matures into an egg ready for fertilization.
Right.
Well, some women may still menstruate on PCOS, and I see that. They're thinking, I get my period all the time, but they don't ovulate.
Right.
And the problem, and that, a lot of times they don't realize there's an issue until they can't conceive. And that's why fertility, is an issue. But when there's no ovulation, there's no corpus luteum left behind. It doesn't mature, which leads to a deficiency in estradiol and especially progesterone, which was secreted by the corpus luteum. I think we both agree progesterone is our favorite.
Progesterone is absolutely my favorite. I'm telling you, I never leave home without my Prometrium.
I know. So
it's an interesting concept, right? That the egg, there is a misconception that there needs to be ovulation in order for a period to occur, right? And that's not the case. So you can still have a period, but you didn't necessarily ovulate, or you didn't ovulate a egg that is mature enough to be able to be fertilized, right? And so from there, when that anovulation or the lack of ovulation is happening, we don't produce enough progesterone because the egg actually has to be released. And then what's left behind where the egg once was is where the progesterone is made, right? So if you're not getting that ovulation that's regular, you're not actually producing enough progesterone, which is so important. Progesterone is important for maintaining mood, anxiety, depression, but also it helps us with sleep. So getting good sleep and managing PMS symptoms. So also, the last thing I'll mention about progesterone before, sorry to take this over because you got me talking about progesterone and I'm obsessed with it.
Me too.
Is that it also protects our uterus, right? Because it protects us against that sort of having balance with estrogen to sort of prevent that proliferation, that growth of extra cells in our uterus, which can then lead to uterine cancer. So not having enough progesterone is a concern. And we know that women who have PCOS are at a higher risk of developing uterine cancer. And we know that that's because of a low progesterone, something I didn't learn until I really got into functional medicine and understanding bioidentical hormone replacement therapy and really diving deeply into perimenopause and menopause. And it was a light bulb aha moment for me.
Yeah, most definitely. And insulin resistant also affects the body's metabolism of nutrients. When our cells are insulin resistant, they don't have enough glucose, so they stay in the bloodstream longer. We feel tired, sugar crave, experience dreaded afternoon naps. We'd have the hypoglycemic effect, like I mentioned. That all creates systemic inflammation, which again causes more problems, weight gain. But, back to your point, our point about talking about women who still have their period, then they don't necessarily fit the criteria of being even looked at for PCOS. So again, how many are undiagnosed with that? And there are a lot, that we're taught to believe that PCOS is abdominal obesity. That's not always the case because there's a large amount of women who are in a class called TOFI, right? Thin outside, fat inside. That inflammation and visceral fat is creating havoc that a lot of times we don't see until perimenopause and menopause, when we lose those protective hormones. And I've seen this in my practice, right? So much going on. No wonder it's such a complex disorder. But again, root cause is the insulin, the high insulin. Back to what you mentioned, the blood sugar highs and lows can lead to mood swings, irritability, and even anxiety, and that low progesterone, right? Then you have sleep apnea, infertility, all kinds. It's a vicious circle.
It is, yes. Well, that's just it. And really back to your point about the misdiagnoses, I mean, now in my medical aesthetics practice, when I have ladies coming in for treatments, it's not uncommon that they'll say, I had great skin and now all of a sudden I have acne. I have adult acne. What's going on? And asking them just a few questions, I can confidently say, you are a patient that has experienced PCOS or still has PCOS. I mean, of course, it's a chronic condition. and you've not been diagnosed. And I remember, again, that was another light bulb
Mm-hmm.
moment in the last WorldLink course that I took, where Dr. Lussier said, any patient that presents with adult onset acne is PCOS until proven otherwise. There's no other reason for their adult acne, you know? And I mean,
Mm-hmm.
I take that with a grain of salt because, of course, we know in the aesthetic world, there's lots of other reasons, but it's
Mm-hmm.
interesting how I have been able to diagnose numerous women since that. Whereas before I would never have thought, I thought, well, you would have been diagnosed by now, you're now in your late 40s and your 50s.
Mm-hmm.
Why is this all of a sudden happening? And sure enough, it made so much more sense. But you're right. There's also that population that's sort of coined as skinny fat, if you will,
Mm-hmm.
right? Where externally they don't fit the body type of somebody who has PCOS, who is typically a little overweight, or there can be significant obesity, depending, where you look at them and think that they don't have the body type to fit a PCOS patient. But in fact, that again is not a criteria, right? And they
Mm-hmm.
could still be having periods and still have PCOS. So it is super complex. And I'm not surprised that, so many women are misdiagnosed with understanding just these three criteria that we sort of used to follow, right? Understanding the pathophysiology of the condition is so helpful and so powerful, because then we know what to do, how we can treat it, and how to help women feel better.
Absolutely. And we live in a society of stress. I mean,
Yes.
sometimes just stress of technology, like this morning. But, adding fuel to the fire, you have this woman who's like on this treadmill of what's going on with me. Then we have everyday stress. We have deadlines, we have finances, we have children, we're aging, unwell parents, all of that, and I think we underestimate fully don't understand the downstream effect it also has on our hormonal and metabolic function, and sometimes making PCOS symptoms even more challenging, because a lot of clients I see have even an underlying stress response. We'll do their cortisol levels and they're really high, and they're like, well, I don't feel stressed. But
Mm-hmm.
it's any time, it could be emotional, physical, it's any time the brain perceives a threat triggers that HPA axis response. HPA axis is the hypothalamic, pituitary, adrenal axis, a great feedback loop that we have in our system to help protect us. So the
Yes, of course.
hypothalamus, sort of command center of the brain, senses that there's stress and signals the pituitary gland, which releases that hormone from our adrenal glands located above our kidneys called cortisol. It's our primary stress hormone, our fight or flight hormone. And it's great in short term, because its purpose is to keep this body alive. But what it does is it also raises blood sugar levels, increases our
Yes.
heart rate to give us that boost of energy. So now we have even more circulating sugar. It doesn't affect, like insulin doesn't trigger it, but it's the excess glucose time after time after time. So although we know insulin resistance is the root cause, sometimes it's about really dealing with the cortisol and trying to kind of settle everything down in order to address the insulin resistance. So every woman is different, and it's
Yes.
understanding where they are in their journey and, giving them, some recommendations that are going to have small, wins along the way before they go on to the next one. There's no, unfortunately, pill that's going to fix it. No pill, or conventional medicine, or, we're used to a pill for this symptom or that symptom. There
Right.
isn't. And it's
Yeah.
finding what helps. So stress is another thing that sometimes we have to address before the insulin resistance, because high cortisol, high progesterone. There's that progesterone again. See what it does? It
Yeah.
robs our progesterone, right? And chronic stress reduces even more of the progesterone levels. Taking our calming hormone away increases more anxiety and sleep. And I see a lot that have really bad PCOS symptoms that have not found it earlier, have developed some stress coping mechanisms that are perhaps unhealthy, like overeating, not for any fault on their own. It's just they're trying to figure out their body and feed their body, so it's just making it worse. I always say, let's deal with the stress, find some coping strategies, being mindful thinking, breathing, yoga, something to decrease that glucose spike.
Sure. And again, thinking back to sort of primal days, if you will, that the whole pituitary adrenal axis that you were chatting about before. I mean, if you think of, we're being chased by a lion, right?
Mm-hmm.
So what's happening is our bodies, we're depleting all of this energy because we're running really fast to save our lives. And then in those moments where you're calm, you're eating a ton to be able to replenish that, right? So it's these highs and these lows, these highs and these lows. But if you're running from that lion every single day for hours at a time, eventually your adrenal glands are going to poop out, right? They've had enough.
Mm-hmm.
They've made enough cortisol and they don't want to make any more cortisol, right? And of course, that's then going to affect your insulin. It's going to affect your thyroid. It's going to affect your ovaries. And certainly you're not going to be ovulating while you're running for a lion or from a lion rather, right? That's not the time to get pregnant. So
No,
it's really
exactly.
it's a vicious cycle. So we don't appreciate in conventional medicine just how important stress really is and how stress affects sleep. And then again, in walks progesterone, how it can help with both of those, because if you're getting a good night's sleep, then we know that, you're better during the day. You're not going to feel as overwhelmed with routine things in life or routine little stressors that pop up. But if there's continuous amounts of stress that's not being managed, that is going to inevitably affect all of your hormones. I mean, there's just no way around that. So we can only take stress for so long before our adrenals, like I said, sort of poop out, right? So really important. And it's hard in our society, especially I think in perimenopause and menopause when we have perhaps teenagers or young children, if we had children later in life, we have aging parents, we have careers, we have partnerships. There's so much going on that it's really difficult to manage stress, but it needs to be at the forefront for sure.
Yeah, absolutely. Absolutely. And the other thing you touched on was thyroid also, right? Thyroid is another one of my favorite because it's our master metabolic hormone. We need that to function. I always say it's like the gas in the tank. And I do a full thyroid panel with the TSH, T4, T3, and even in some cases reverse T3, because then I can show them when the reverse T3 is very high, there's reasons why the T4 and T3 are not converting, and it's that T3, that's the active thyroid hormone that goes into the cell.
Right.
So, that's another very important metabolic hormone that we look at as well.
If I can chat about thyroid for 1 second, back in, the conventional ways of doing things, really we were taught to only check a thyroid stimulating hormone, right? And that's where the pituitary again is sort of whipping the thyroid gland into saying, hey, make more thyroid. It's this hormone that's being produced to do that. And so we would treat, if the thyroid stimulating hormone was high, then a patient would be diagnosed with hypothyroidism, right? Meaning that they needed more thyroid hormone. Or if it was too low, then there was too much thyroid hormone floating around. But there was never any emphasis in understanding the different thyroid hormones that are made. And so again, it wasn't until getting into functional medicine and looking at things from that perspective of prevention and sort of that holistic view of the whole person, not just treating the symptom, that I realized the importance of looking at a T3 level and a T4. And I always explain to my patients that a T3 is the money in your wallet. It's what you're going to go spend at Winners to buy that cute little pair of shoes that you wanted, whereas the T4 is the money that's in your bank. So you actively need to go to the ATM or to your bank, put your debit card in, and withdraw money. So there is a conversion from electronic currency to money in hand, right? So when people hear it from that, with that analogy, it makes a lot more sense as to why those hormone levels are important. Because if your debit card's not working and you can't convert it to T3, then it's not usable, right? So you can have all the stores in the world, but you can't actually access them. So that's why looking at not just the thyroid stimulating hormone, which in my opinion is the most useless of the three, looking at the T3 and the T4, and then a reverse T3 if needed. I tend to reserve that one in complex cases where I'm not quite sure what's happening and I need a little more information or another piece to the puzzle, because you do have to pay for it. I think it's $100 here in Canada. But it's worthwhile to check in a case where you're not sure. Otherwise, I just tell patients to take selenium because it's not harmful anyway. And we know that when we can feed the thyroid selenium, then that conversion from T4 to T3 tends to improve. So again, just another way of approaching the whole body, whole person, and understanding what's happening and really giving the thyroid the respect that it deserves, because coming from a South American family who we all like food, and we've all sort of struggled with our weight at one point or another in our lives. I remember my aunts and my mom and just family members in general chatting about your thyroid. Oh, you've gained weight. Did you talk to your doctor about your thyroid? It must be your thyroid, right? The thyroid had all of this, sort of burden of weight gain. And when I was, of course, in NP school and then learning from wonderful physicians later on in my career, the thyroid was sort of dismissed. It's not the thyroid. You just check a TSH and there would be some older docs that I learned from who said when patients come in wanting to check their thyroid because they're overweight, they're just lazy, right? It's not their thyroid. And, that really, it didn't sit well with me because I thought that doesn't make a whole lot of sense. And then of course, heading into functional medicine, looking at, again, full body and the importance of the thyroid, and really how used and abused the thyroid is along the axis, because it's so important for metabolism, so important for just that energy level. It really just made a lot of sense, right? And I think, there's a lot of patients that I saw years and years ago that probably did have a non-optimized thyroid, not meaning that their thyroid was sick per se, that needed, intervention, but replacing a bit of T3 and T4 by means of something like desiccated thyroid would have made a world of difference, but it wasn't on my radar.
Thing.
Yeah, I feel like sometimes I wish I could go back and see all the patients that I saw and approach their care with, through the lens of functional medicine, because I, would have been able to help so many more people. But again, you only know what you know. And I'm so grateful that I decided to take the leap and to learn more because, now I actually feel like I'm really helping, not putting Band-Aids on problems, right? And I'm sure you feel the same way.
I feel the same way in, now the people that we can help moving forward that sometimes don't even realize they need help.
Yes.
Right.
Yes. Exactly. I think it's important to still rule out. You have to rule out all of the possible conditions,
absolutely.
But being able to approach it from this perspective really does open up so many doors, and it provides a lot of hope for patients because there are actual actionable things that they can do, whether it's lifestyle modifications or supplements or actual medication that can help and really change how they're feeling for the better, as opposed to saying there's not much we can do or take an oral contraceptive in the case of PCOS.
I know so many women I've seen, they said, my primary care, my doctor said I had PCOS and I'll never get pregnant. Bye. Just dismiss them. It was like, I left them there, it was like,
No,
yes, now we have the ability to, help people.
For sure.
And the earlier, the better.
100%. Exactly. And the thing too with thyroid is that we know in perimenopause and menopause, about 18 to 20% of women, as they head into that stage of life, do end up having an underactive thyroid, or what we call subclinical hypothyroidism. But what's interesting is, again, in my learnings about PCOS, is that there is a large, I don't know if you have a specific percentage of women who have PCOS that also have thyroid dysfunction. I don't have the exact number, but I remember learning that, again, it's not something that's looked at enough in relation to PCOS management, and it makes perfect sense. So again, understanding the way that the thyroid hormone works and how it can help a woman, not only with weight management, but just energy level, with sleep. All of these things is vital.
Absolutely. And a lot of times that's part of the treatment plan, even a low dose. If they tried the selenium, the zinc, all of the nutrients that help with the conversion still don't work, then we might boost it with a little bit of thyroid to help them along. So they don't get discouraged because, PCOS, we transition into a perimenopause, and talking about the similarities, there's significant hormone fluctuations that can lead to weight gain, mood changes, even more metabolic disruptions, like you say, low thyroid. And the other main hormones that are key players, of course, are the progesterone, estradiol, and testosterone. And in PCOS, progesterone levels are often low due to the irregular absent ovulation, like we talked about. And during perimenopause, you're already starting at that low level, and now it's declining even more. So a lot of women are surprised that, early on, their progesterone is at postmenopausal levels. And they're having, mood instability, anxiety, trouble sleeping, all of those things we talked about that progesterone helps with. And then there's estradiol. Women experience erratic estradiol levels in perimenopause. And then you have that gradual decline causing symptoms like hot flashes, night sweats, probably sooner than later because of the drop in progesterone, if not.
Yes.
And then, with the decline in estradiol, we make insulin resistance even more pronounced. This means, the women with PCOS may struggle even more with weight gain and metabolic issues. So it's just, again, another negative as the estradiol drops. And then we get into, complications because estradiol protects the heart, our bones, our brain, a vagina, urinary incontinence, all of that wonderful stuff.
Yeah, and that has been in my clinical experience. I have really seen that the women who have a history of PCOS or who have not been diagnosed do have a more profound and faster sort of onset of perimenopausal symptoms. So even though, they're in their early 40s, the night sweats, the hot flashes, the vaginal dryness, the mood swings with the premenstrual syndrome, it is so much more profound than women perhaps that don't have PCOS. So, and that makes sense again, because that sensitivity to even further estradiol loss and progesterone, right? So it's not just the regular amounts that you would see in sort of regular perimenopause and menopause, because again, it's so different for so many women, but it's even more profound in PCOS, and it's tough. It's tough.
For sure. And then you have the estrogen declining and even more weight gain.
Right, which is discouraging. And that is one of the first things that women chat about is their weight gain. And it's almost always that visceral weight gain around the belly that they talk about that is super frustrating for them. So tell us, let's give our listeners a lot of hope here, because there are a lot of wonderful things that we can do to help treat PCOS and then PCOS again in perimenopause and menopause. But tell us your secret sauce, if you will, of how you help these women feel amazing.
First and foremost, we try to look at priorities. Like I mentioned earlier, of course, we look at all of the metabolic issues. The history sometimes give us more information than the labs. See where they are in life. And first and foremost, I always try to manage the cortisol, so help give them, some tools, whether it's, like I said, mindful breathing, yoga, something that's going to help calm that cortisol. I like devices, a lot of people like to use the Oura Ring to help them sleep, Headway, different calming apps to help them kind of shut their mind off. And then we, lifestyle and diet is a huge one. We didn't really talk about exercise, but exercise is extremely important in glucose management. Strength training, cardiovascular training, all of that really helps, because it helps glucose metabolism.
For sure.
Doing, try and be active. And you can't expect someone, I wouldn't say, yeah, you need to join a gym and do this and that. Again, meet them where they're at. I say even 30 minutes a day, move, do something. And then, of course, the big one to help with insulin resistance is, food. We have to think of food as more therapeutic, right? And eat therapeutically, I say.
Yes.
And look at more of the Mediterranean, which is not like diet means you go on, you go off. And that's why I say food plan, because you want to sustain it. This is a way of life. This is a way that you're going to help with insulin resistance, which is in turn going to help prevent diabetes, help prevent cardiovascular disease. You're helping all of those cells so that they can get the nourishment they need.
Yes.
And that's sometimes a hard one, but we have to, do little steps. And it's interesting because someone who's really motivated, you'll see a difference in 10 days and it changes your whole microbiome. It changes the sleep. It changes, your skin sometimes, a lot of great things. So we look at exercise being any kind of physical movement. Nutrition has to be, right there with managing the stress, and it has to be sustainable.
Agreed. Would you say that even walking at a decent pace where you're getting your heart rate up a little, you can still have a conversation with a partner or a friend if you're out for a walk with them, but a good 30-minute brisk walk a day is a good starting point?
Yeah, and that's honestly, Jessica, where I tell them to start. It's like, just walk, and even if that means parking your car the furthest away from the store, get that walk in. Just consciously think of just walking. Absolutely. 30 minutes a day to start,
And it can be a
then
stress reliever too, right? Just that getting out into nature, whether even if you live in a highly populated city, just getting out and getting some fresh air can be very therapeutic for sure.
absolutely. And then, we look at the vitamins and micronutrients, and vitamin D is, been reviewed many times and shown low in PCOS patients, but in my practice, it's low in everybody in this area where we live, this climate. Unless you supplement, really, everybody is deficient. And vitamin D doesn't get the, I think the credit it really needs, because it's so vital in, not only gut health, which helps with mental health issues and neurotransmitters. It's also a pro-hormone. I call it the orchestra
Yes.
leader.
Yes.
My clients have heard me say this. It's the orchestra leader. If your vitamin D doesn't come, to the performance at the top of their game, then nobody's going to perform, right? So
Yes.
it's extremely important. And vitamin D helps with energy too and metabolism. So I always make sure we optimize their vitamin D. And some other, supplements that I would recommend. I mean, stress too. I like ashwagandha. If they're
Yes.
really stressed, ashwagandha is just a natural root that really helps to calm the system down. If they need help with that, I mean, I don't say this is what you need, try on your own. And if not, supplement. And then there's inositol or myo-inositol, which is insulin sensitizer, much like metformin, but in more
Yes.
natural phase, and 2,000 grams twice per day. A lot of people tolerate that better sometimes than the metformin.
Are there less side effects like GI, belly upset, diarrhea, that kind of thing with the inositol, have you found, versus the metformin?
Yes, absolutely. Especially if they take it with food. or at least 20 minutes
Of course.
before food. If they take it on empty stomach, then they will have those, much like metformin. But for the most part, they tolerate it really well. Again, it's not an instant. It's along with, the lifestyle changes. And I think lifestyle changes are, the biggest things that we have to realize that are modifiable. We can modify everything with lifestyle changes, with therapeutic food and movement that is going to really have an impact. The
For
other
sure.
thing that I've found recently that has been very effective, I know there's been studies on NAC and acetylcysteine. It's a precursor to glutathione. And glutathione, it's my favorite, it's an antioxidant. And it's been shown to directly affect hormone balance by reducing oxidative stress and inflammation.
Amazing.
Right? Which are factors that contribute to hormonal imbalances. And there's so many, uses of glutathione. I know it helps with skin lightening, but I have used glutathione on my patients that their family members came in and said, I want what she has.
I want that.
Yeah,
Now,
I want that.
Are you administering it through like an IV drip, or are you doing intramuscular injections? What's your favorite way of administering?
In the case of a PCOS, I am injections.
Okay.
So it would be like biweekly or even monthly,
Okay.
depending on, their goals, how fast they want to get better. I do it in IVs also, but I find the IM injections, if they come in, every 2 weeks, it's just a little bit easier for them, less expensive
For sure.
too.
And it's faster too. And so for those of you that don't know what an IM injection, it's just like getting the flu shot or a B12 shot, where it just goes into the arm, or, in some cases, maybe in the bottom, right in your glute muscle, depending, but usually it's just in the arm. So it's a super easy peasy, quick little injection that can be given, and it can be highly effective. So that's great. So there are so many things that a woman can really do to help with PCOS. And again, this is not just regular PCOS, also PCOS in midlife. I know that in the case of PCOS in perimenopause and menopause, I tend to be more aggressive with my progesterone replacement in women.
I would do that too.
Yeah. I find that going up, 2 or 3 times the dose, depending on the person, of course, their body mass and how much they're tolerating the progesterone. Again, using bioidentical, which is Prometrium here in Canada. It works really well with helping with mood and sleep, and also the PMS symptoms. And then if there is heavy bleeding as well, still in that perimenopausal phase, it can also help to minimize how many days and the heaviness of the period as well. So it really is a wonderful option as well as starting estradiol a little earlier as well in some women. I tend to hold off using estrogen in perimenopause if a woman is still regularly menstruating. Of course, that's telling me that she likely doesn't need much estrogen replacement. But later on, when their periods become much more sporadic, that's when I tend to start the estradiol, which is bioidentical estrogen. But in the case of PCOS, I might start a little sooner, understanding again that the estrogen levels are lower as well. So there are lots of things that can be done. Sometimes I find that it's difficult, and having been there myself, I know that when I have felt tired or have felt like I couldn't get a grasp of, my weight management, it was really overwhelming to think of all of these things okay, I've got to start 7 supplements. I have to start walking 30 minutes a day. I've got to, not eat carbs and all of this stuff. And I have found, as I've gotten older and a little wiser, that if we can just pick 2 or 3 things and turn them into sustainable change, that's when we start seeing changes. And if I had to pick of everything that you mentioned today, I would say that walking 30 minutes a day is number 1. Because that's going to help with stress and relaxation, and also get that movement in so you become more insulin sensitive. 2 would be, a lot of people are afraid of sort of that conversation around low carb. And that's why I tend to talk about the Mediterranean diet as well, where the focus is more so on whole foods, right? So staying away from processed foods, but more so things like veggies, low glycemic index fruits, meaning fruits that don't have a ton of sugar. So your body takes longer to process and digest as opposed to just getting it through your system and spiking your insulin. So things like berries are fantastic. So any type of berry is a good starting point. And then focusing on protein intake, really, right? Because a lot of women just don't get enough protein. And we're going to get into that in another episode where I have the pleasure of interviewing another guest who is well versed on weight training and also protein intake for women. But for now, I would just say the goal should be around 1 gram of protein per lean body mass pound. So meaning that, let's say your goal weight is 140 pounds, you should be getting around 1 gram of protein per pound per day. And that might seem daunting to think, oh my gosh, I've got to get 140 grams of protein in there, when if you took a good look at your diet, you may only be getting 50 grams, but anything more than 50 grams is better than 50 grams, right? So that slow increased ability to increase that protein into your diet and have that sustained change is where people will actually feel better. And then the third one of everything that you've just said is vitamin D. I am a huge fan of vitamin D. It is the sunshine vitamin. We don't make enough. You're right. Any North American, I think when I've looked at all of the patients' labs that I have ever collected, I have had maybe less than 10 people who have been normal. And conventional normal is very different to functional medicine normal.
Thank you.
You know, we like to optimize, not just be normal. Nobody wants to get 50% on an exam. We want to get 99 to 100. So,
100%.
you know, we want that optimization, and we don't make it. We make about 10% with exposure to sun. And think about, as soon as our clocks go back and it gets dark by 5 p.m. and our mornings are dark until about 7, 8 o'clock in the morning, when are we supposed to synthesize vitamin D? It's just not something that...
Sorry, and then it's lap.
Exactly. Yeah. And then those of us in the aesthetic world that are SPF obsessed and make sure that our face doesn't see any sunlight. And if it does, it's covered with some zinc-based SPF. So, you know, it's easy to replace. It's a fat soluble vitamin. Like you said, it's a pro-hormone. It's really important in all the things, and it's inexpensive. You can get a whole bottle of vitamin D oil or the oil glycerin capsules. Public service announcement, if you will. Stop buying the white tablets, the vitamin D white tablets. They are useless. They don't absorb well. They should be taken off the shelf. Please get oil drops or the glycerin capsules. It is a fat soluble vitamin. It's meant to be in fat base, and it needs to absorb that way. So yeah, so lots of wonderful things that women can do to feel better. So I honestly am so thrilled that you were able to come on today to chat about PCOS. Are there any other thoughts that you wanted to share before we wrap up our episode?
I just want to reference one of Dr. Fung's books, you know, for a reference for time restricted or intermittent fasting. A great resource I highly recommend. It's called the PCOS Plan by Dr. Jason Fung and Nadia Pataguana. She's an ND, both from Canada. Wonderful resource. They really go into at a digestible level on how to, you know, help manage your insulin resistance. So a good resource.
Amazing. And Dr. Fung, as I mentioned in my last episode, he is an incredible physician that is based in Toronto, Ontario, has done a lot of work around insulin resistance and diabetes management. But this resource specific to PCOS is fantastic. So we can definitely add that link in the show notes for people to access it on Spotify or wherever it is that you listen to your podcast. So be sure to check out the show notes for that link. So Agnes, I wanted to ask you 2 questions that I'm going to be asking all of my podcast guests. And starting with, what's a question about PCOS that most people are too embarrassed to ask you, but they should?
It's probably around weight. I think weight is a big issue. I mean, even though, you know, they present like they can't lose weight, I think talking about that out loud is very difficult because, you know, as you mentioned before, it sounds daunting to deal with.
Yes.
So, you know, dealing with addressing the weight, if that makes sense.
Well, it can be embarrassing for some women too. It's something that has, been upsetting to talk about for many, many years. And perhaps they've been dismissed by other clinicians too. So there's a lot of sensitivity around that for sure. So I could see that being one of the things for sure. And again, it's when you have that relationship with your patients and you're looking at every system in their body as contributing to their symptoms, it makes it easier to talk about things like weight, because again, it's something that you're addressing and you're asking about, right? As opposed to just skirting it, or not paying attention to something that's important. So,
right.
So that's great.
Making them feel safe to be able to really talk about it.
Yes, 100%. So then here at the Hot Flash Diaries podcast, and of course at Bonita Medical Aesthetics and Wellness, we believe strongly in self-care as an effort to feel bonita. So tell me, what is one thing that you do for yourself, either daily, weekly, or monthly, to feel bonita inside and out?
Epsom salt bath.
I love you. I love you.
Salt bath in my jetted tub, yes, with a candle, and my spa music. It's just, I detach from the world. And
how often do you do this?
Well, more in the winter than in the summer, and but I like to do it weekly. Definitely.
That's so amazing. I love Epsom salts, and I honestly prescribe it for everything from sore joints to period cramps to wounds to all the things. I love Epsom salts. They are underrated. And my family laughs at me because they don't even come to me with their ailments anymore. They just go and do an Epsom salt soak. And then I say, well, see, you feel better. So.
You have receptors everywhere, so you absorb it quick.
Yes, it's a great method of reducing inflammation, and it's just soothing. So that's great. So there you go. You've heard it from the expert. Agnes agrees that Epsom salts is the way to go.
100%. And the other thing I like is being outside. Being outside.
So important.
In the summertime and just, being outside.
Amazing. Yeah, we don't get a lot of outdoor fun things to do in Ontario, especially you're in Peterborough, so you get quite a bit of snow as well, unless you're into winter sports, which I am not. But although I do share or spend a lot of time in hockey rinks because our one kiddo plays hockey. But aside from that, I'm not a fan of anything cold. But yeah, it's good. Being outside and just especially on a sunny day is so, so therapeutic. So tell our listeners where they can find you, your Instagram handle, and how to get a hold of you if they wanted to connect.
Okay. NP_optimal health. I'm in Peterborough. That's my Instagram handle. You can also reach out to npoptimalhealth@gmail.com, send an email, send a DM. Feel free to reach out.
Amazing. We'll put all of that information in the show notes too, so people can reach out if they'd like to connect with you. Thank you again for being part of the Hot Flash Diaries podcast as our first guest. So very special. We appreciate your time and this wonderful conversation. I hope that everyone has a better understanding of what PCOS is, how to manage it, and hopefully they have more of a sense of hope and, seeing the light at the end of the tunnel if they are experiencing PCOS themselves. So
I just want to say thank you, Jessica. It's been an honor, and thank you for, help educating people.
Thank you. I appreciate that. Yeah, there aren't enough resources out there for women. So I am so glad that I have great colleagues like you to turn to and get you on here to talk about your expertise. So thank you. So next episode, we're going to be chatting about libido. But not libido as far as hormones, but more so the sexual component of low libido. And we're going to talk about all things around sex therapy and different things that we can do above and beyond hormones. And I have an incredible guest who is a therapist. She has a special interest in sexual health and intimacy. So I am so pumped to have her on, and that will be episode number 5. So stay tuned for that as well. And as always, you can subscribe to the Hot Flash Diaries podcast through whichever platform it is that you listen to podcasts. And I look forward to seeing you again. Have the best day.